I think the title is good because I'm going to discuss situation where synchrony, and I think by synchrony we mean synchrony between the patient and the ventilator. So situation where synchrony is good, but also situation where synchrony may be bad or harmful. So these are my conflicts of interest. We all want ventilated patients to start as early as possible having some spontaneous breathing activity. I'm not going to go into details, but we have very strong, not only experimental, but now clinical data showing that the diaphragm especially can very rapidly go to atrophy if it's not used. And therefore, to preserve respiratory muscle function, which will be important for winning, but also for long-term consequences, trying to promote spontaneous breathing as early as possible is really something which looks very important. And there are also a number of mostly experimental studies which suggest that having spontaneous breathing activity, diaphragm activity probably during acute lung injury or ARDS, improve VAQ relationship, so it may improve regional ventilation by reopening some part of the lung close to the diaphragm or the respiratory muscles. And in this regard, we think that having a good synchrony between the patient and the ventilator is probably something important. I listed some of the clinical issues where we think that a good synchrony and a poor synchrony makes a difference. I will show very briefly one example about sleep in the ICU. The synchrony may be important for respiratory muscle function because otherwise the respiratory muscle may work in situations where the shortening of the muscles will not be at the same time than the increase in volume, and that may not be good for the muscle. We have question mark about the importance of synchrony in terms of comfort, need for sedation, but it may be something, it may be playing a role there. And we have also examples where asynchrony makes more complicated winning assessment, which may explain the relationship between the number of asynchrony and the duration of ventilation. And also another important aspect is that for a lot of asynchrony, we have tools to minimize this asynchrony. So it may matter, it's associated with duration of ventilation, and it's possible to minimize. But there are also possible, other possible situations, which I put on the other part, where a good synchrony between the patient and the ventilator may not be desirable because it may simply amplify the transpulmonary pressure swings, which may harm the lung, and it may also facilitate over-assist, which is a very frequent event in the ICU. One example about sleep, very nice study performed by Sai Parthasarathy and Martin Tobin. They compared during the night the same patient ventilated with assist control for a few hours versus pressure support ventilation. You have all the typical recordings of polysomnography with EEG, the eyes motion, some EMG recordings, the ventilation, SpO2, and EKG. If you just look at the pressure support part, you see that when you look at the line indicating VT, that there are frequent interruptions in ventilation. And this is intermittent apnea, episode of apnea. And if you look at the top of the slide, you see the white bars indicate the arousals and awakening episodes. And what you see is that after each apnea occurring during pressure support ventilation, there is an arousal or awakening. So if you think that patients in the ICU are more or less sleeping maybe 18 hours a day. One of the reasons is that because their sleep quality is very, very poor, it's a very, very fragmented sleep. And here, there was a clear association between an effect of the ventilatory support and the sleep fragmentation. On the part indicating assist control, you see much less of this arousal, probably simply because there is a backup ventilation. When trying to understand what was the reason of this episode of apneas and arousal, they simply added a third part to the recording, which was adding a dead space to pressure support. And by adding dead space, of course, they increased PCO2. They did not induce hypercapnia. They probably normalized an hypocapnia, which was induced by excessive level of pressure support. And when doing that, the number of arousal plus awakenings decreased even more than with assist control, and the sleep efficiency increased. So very nice relationship between ventilator settings, patient-ventilator interaction, and a very clinically relevant outcome, which is sleep fragmentation and sleep quality. We also have data indicating that poor asynchrony, and this was a prospective observational studies we did in a group of 60 patients in the ICU. Poor asynchrony indicated by a high asynchrony index is associated with a very, very higher duration of mechanical ventilation. You may say this is just an indicator of severity, but when you compare the tidal volume used in patients with high asynchrony, the pH level, the PCO2, you just see that these patients are hyperventilated. They have higher tidal volumes, they have lower PCO2, they have more alkalotic pH. So maybe suggesting that one of the reasons they have asynchrony is because we give too much support to these patients. And in fact, in a later study, we show that in many of the patients, it's possible to reduce or to suppress a number of the asynchrony. And most of this asynchrony, as indicated on the tracings, were ineffective efforts. So patients being hyperinflated by the excessive level of assist we were delivering to these patients. And you see here that by simply optimizing the pressure support level, in many patients, not all, the asynchrony index could be markedly improved. No demonstration that this changed the outcome of the patients, but a demonstration that it's possible to do something about this asynchrony. And this nice study from Marshall and David show again a very large difference in the duration of ventilation with or without asynchrony. And interestingly, they used a multivariable model to demonstrate that the presence of asynchrony was an independent factor associated with long duration of mechanical ventilation. So in general, we do think that asynchrony is bad and that we try to reduce asynchrony, and I think it's reasonable. However, and maybe because the focus of this session is a lot about ARDS, we have something very disturbing from the standpoint of trying to promote spontaneous ventilation and promote good synchrony. This study by Laurent showed that if you give neuromuscular blocker, so if you completely shut off spontaneous breathing during the first 48 hours of ARDS, you're not only showing that there is no harm with neuromuscular blocker, but you're showing an improved outcome. An improved outcome by suppressing spontaneous breathing activity. And the reason for that are not exactly clear, but very likely this is due to the effect of maybe an excessive level of spontaneous breathing activity, or maybe synchrony between the patient and the ventilator. So you see very nice hypothesis on this cartoon, which indicate what can happen without paralysis and the usual mechanism for inducing ventilator-induced lung injury, because we think that what we see with neuromuscular blocker is less ventilator-induced lung injury. And ventilator is probably not the good term, because part of it's in fact ventilation, a part coming from the ventilator, a part coming from the patient. So I would say for the clinician, that's really difficult, because there is one day where we have to stop paralysis, and so I'm not saying from this study that we should give paralysis to every patient all the time or every ARDS, but we need to better understand what's happening. And in this situation, when you decide to stop paralysis, you cannot continue for long, or when you decide it's not needed, to choose the right mode of ventilation, which allow correct gas exchange, to protective lung ventilation, but allow some spontaneous breathing activity, that's very difficult. And in this instance, it's important to come back to the basic principle of the modes of ventilation. For instance, if you think about volume-controlled ventilation, I indicated here the airway pressure and the esophageal pressure. So the red arrow would be the transpulmonary pressure, the difference between the two. In volume-controlled ventilation, the advantage of this mode is you control volume, which means when the patient is spontaneously breathing, we say triggering the breath, the transpulmonary pressure will not change, and that's why you see fluctuation in the airway pressure. So the advantage of volume control is that you control the volume, so you control the transpulmonary pressure. However, very often that's not very comfortable for the patient, and this is the main reason why we switch to pressure control or pressure assist control ventilation. But in this situation, if the patient is taking larger effort, the airway pressure will not change, but the difference between the airway pressure and the esophageal pressure will increase, therefore the total transpulmonary pressure will increase. So with pressure-controlled ventilation, any form of pressure-controlled ventilation, you do not control transpulmonary pressure. So again, very difficult choice, a mode which is more comfortable, but where you have less control of transpulmonary pressure. And we have a number of modes which make spontaneous breathing feasible, easy, without inducing a lot of alarms on the ventilator, and which are called by many different names, but they're all pressure-targeted modes. And the main characteristic of this mode is that the expiratory valve is always open. Always open means that at any time during the high pressure or the low pressure, spontaneous breathing is possible. So like CPAP, but at 2 levels, and you can use this mode with mandatory pressure breath sufficient to ensure gas exchange, plus time for the patient to have spontaneous breathing, either during the high pressure or during the low pressure. In this situation, however, the ventilator company thought that it would be better to synchronize, and we come back to my topic today, to synchronize patients' effort with either the increase in pressure or the decrease in pressure, and this is a very classical technology for ventilators. They just have a window during which they wait for a signal coming from the patient, and when the signal comes, they deliver the breath at the same time. And the same can be done for expiration. So most of the modes of ventilation using pressure-targeted objective have this synchronization. So if you carefully look at all the pressure preset mode, pressure targeted modes, you can find one mode where there is no synchronization. This mode is called APRV. And this is very confusing because APRV is usually used with a very long, not inspiratory, but high pressure time and a very short release. There are modes where you have partial synchronization, let's say SIMV, pressure control, where you can or cannot add pressure support during the low pressure level. And you have modes, which are the most frequently used, where every breath is synchronized with the patient effort, like pressure control assist or pressure support ventilation. And just imagine again something very simple. This would be the tidal volumes that you would set based on your initial pressure control level, and you would set 6 milliliters per kilogram at every breath. So this would be a patient without any spontaneous breathing. Let's now stop paralysis. The patient starts to breathe at his own rhythm. And let's say he's not doing strong efforts, but maybe efforts sufficient to perform tidal volume around 4 ml per kilogram, because every effort will be synchronized with the ventilator mandatory breath. Then every breath will be now exactly the same setting, but the patient is breathing. Every breath will be at 10 ml per kilogram. So maybe the best solution, again, for the compromise between lung protective ventilation and some spontaneous breathing activity would be to have no synchronization at all. No synchronization, which would mean that you would have a lot of small breaths, maybe 4 ml per kilogram, which would not participate to gas exchange, but that's not what you want. You just want some respiratory muscle exercise. Some breaths where the mandatory breath of the ventilator will deliver 6 ml per kilogram, and a few breaths where the two will come together and give 10 ml per kilogram. So in this situation, the protective lung ventilation on average would probably be achieved, but with a much higher variability than in the two other situations. In this study published in Intensive Care Medicine, and Jean-Christophe Richard was the first author, this was a bench study where we simulated patients' different kind of inspiration. We had always exactly the same pressure settings on the ventilator. And you see, starting from a non-synchronized mode, which is APRV at a standard setting of pressure, inspiratory and expiratory time, and going to a partially synchronized mode like SIMV, or partially synchronized mode SIMV plus pressure support, or a fully synchronized mode like assist control or pressure support. You progressively increase tidal volume and you progressively decrease variability. So if you think that protective lung ventilation with a small tidal volume and with some degree of variability is maybe the best option, you would prefer to use a non-synchronized mode. And again, the difficulty is that the only way to do that is to use this mode called BiPAP APRV, which does not exist on all ventilators. But to use it exactly with the settings you would use with the pressure-controlled ventilation, so not a long, high-pressure time. And this would be an example of a patient. You see all these small breaths, and at a normal respiratory rate, mandatory pressure at the level needed to give 6 ml per kilogram would be given. This is the way you can monitor the amount of minute ventilation. So you have the difference between the total minute ventilation and the spontaneous minute ventilation. And these are data which were obtained in patients, and just separating the different period of time with regard to the amount of spontaneous activity. Sometimes the patient is doing 50% of the total minute ventilation, sometimes only 10%. And you see that on average, the tidal volume is in the range expected, so delivering protective lung ventilation. And the coefficient of variation is relatively high, so at the same time you do protective lung ventilation, you also have a high variability. These are 3 additional patients where we compare the 3 modes, APRV, SIMV pressure control, called here BiPAP, and assist pressure control, and we had exactly the same result. We just finished a larger study where we enrolled 15 patients, and we are now also looking at the effect on the work of breathing of these patients. So the optimal mode of ventilation, allowing spontaneous breathing, is not something simple to define. It may very well depend on the stage, severity of respiratory failure. In the early phase, controlled ventilation, maybe with neuromuscular blocker, may be needed to be absolutely sure that you deliver lung protective ventilation. I don't know when. I put 48 hours because that was done in Papazian's study, but maybe earlier. We should start with some spontaneous breathing activity, and at that stage I think that a non-synchronous pressure targeted ventilation, APRV without the classical settings of APRV, may be the best compromise, and later on a synchronous pressure targeted ventilation like pressure support may be used. But probably the best response, if these modes would be for clinical use, would be also to add a monitoring of what the patient is really doing using either the esophageal and transpulmonary pressure, either the electrical activity of the diaphragm. Stop there and be happy to answer any question. Thank you.